So I want to give context to where this talk is coming from. I've always been using ultrasound since my residency. I trained with it. I trained with Mike Stone at Kings County. He taught me that it is so vital for every patient that you have to consider using ultrasound, especially in cardiac arrest. And I'd been using transthoracic ultrasound for many, many years until one time as an attending, I was running a code and we were doing ultrasound and we had perhaps a very nice case for pericardial tamponade. So during the rhythm check, we looked with the ultrasound and we weren't quite getting the windows that we wanted to. The team was in place. People were ready to get back on the chest. People were feeling for pulses. The meds were being pulled up. And they said, "Can we get back on the chest?" They said, "Just give me one more second." And we kept looking around with ultrasound, not quite getting the windows. "Can we get back on the chest?" Yes, just we're almost there. If I can find this pericardial effusion, then we can make the diagnosis and save this person's life. And long story short, 30 seconds later, I realized that we didn't get back on this person's chest. Now, ultimately, this person had a poor prognosis rolling in the hospital, but it truly echoed to me, no pun intended, that ultrasound can potentially be harmful for our patients if we're not careful about it. And subsequently, there have been studies that have shown that transthoracic ultrasound can distract you from the things that we do, which are most important, which is pushing on the chest and defibrillation. So we have to find some even ground when we're having patients who are in cardiac arrest and using ultrasound. And that is what I want to talk to you today about, the potential solution where we can find a middle ground, and that's using transesophageal ultrasound or echocardiography for our patients who are in cardiac arrest. So as Sal said, my name is Haney Mallemat. It's a privilege to be here with all of you. I write about critical care topics and critical care ultrasound topics along with all my authors on criticalcarenow.com. Give it a look. We're almost a year old. I'm very, very proud about it. So you can find some of these resources I'm talking about today on that website. But let me give you the 5 reasons why you should be using transesophageal echo. And the first is just simply image quality. We've all been part of that code where we're looking and trying to figure out what exactly we're looking at when we get an image of the heart. And I love transthoracic echo, but I'll be the first to admit that you have skin, subcutaneous tissue, muscles, air, bones, a lot of stuff to get to until you can image the heart. And that is going to impact your image quality, especially when someone is arresting. Now, someone once said the best way to someone's heart is actually through their stomach. And they weren't talking about food. They're talking about transesophageal echocardiography, or TEE. If you're watching from Australia, it's TOE. But what it is exactly is, as you can see in the animation on the right side of the screen, the probe is being inserted into the esophagus. Now, these patients will have to be endotracheally intubated. You can't have a supraglottic airway in, but the probe will go in and the probe goes behind the heart. So instead of in front of the heart, it's behind the heart, only 1 to 2 centimeters, and there's nothing in the way. The images that you get are crisp and clear. Here you have a mid-esophageal 4-chamber view, and you see the left ventricle, you see the right ventricle, the right atrium, and the left atrium. And you might be saying, this looks very familiar, Haney Mallemat. What is this? This looks just like an apical 4-chamber view. And in fact, what I'll say is that there are analogs for all your transthoracic views in transesophageal views. So it's not like you have to learn how to decipher new images. You probably can identify many of these. It's just a mirror image because instead of shooting from in front of the heart, you're shooting from behind the heart. So reason 1 is image quality. The second reason is we want to find reversible causes. And when you get good image quality, you can find reversible causes without a doubt much more clearly. So some of these have been donated by my friends. This is James Fair. Anyone knows he's one of the pioneers in emergency medicine, transesophageal echo. This is a person who came in PEA arrest, but if you look, the person is actually having cardiac contractility. But what you'll notice is that the RV right there is dilated. And when they got more history, it looked like this person had a massive PE. Person got TPA, walked out of the hospital. Another godfather of transesophageal echo in the ED and ICU is Rob Arnfield. This person is getting active chest compressions. And what you can see here is this right ventricle has a clot in transit. The story sounded good for a massive PE, got TPA. This person walked out of the hospital. This is a clip from the POCUS Atlas, a fantastic website for image resources that I highly recommend. Look at this clot in transit. This is in the right atrium right here. So this is a view that you might not be familiar with, but it doesn't matter. The point is you can see clot in transit. This was grounds to give the person TPA. This was a person who came in with IV drug abuse and fever, and the thought was this person was septic. But this person started to get sick, got intubated, couldn't get good windows. And what you can see on the left side of the screen is you see a vegetation there on the mitral valve. And if you look on the right side, you can see color Doppler showing wide open MR. It's not important if you're not familiar with these images right now. The point is look how clear these images are, and you can make this diagnosis with just a little bit of training. Now, I hate Grey's Anatomy. I'm going to go on the record and saying that, because once I saw that they shocked asystole, I was done with that show. However, I've kind of come around because of cases like this. This looks like asystole, but when the TE probe was down, what it showed is actually very fine ventricular fibrillation. This person got cardioverted, and this person got ROSC and walked out of the hospital a few weeks later. The point is you can see things that you didn't see before that are reversible when you use transesophageal echo. Now, it's not always good news, but it can be helpful in cases where you want to terminate arrest. This is Patrick Okersey. He sent me this clip of a person who has an type A ascending dissection. The person came in arrest. They worked them for a while, but unfortunately, as you see with a type A dissection, the likelihood of this person leaving the hospital is very low, and they use this as grounds to terminate the code. So it can be helpful the other way when there's causes that can't be reversible and fix the amount of resource that you invest in that code. As I said before, what led into this is time on the chest. Truly important when you're resuscitating patients. The pulse check, rhythm check doesn't have to be 10 seconds. It should be as short as possible, but certainly shouldn't be 30 seconds. And that is because time is perfusion. Perfusion to the heart, perfusion to the brain. And so you have to get back on that chest. Now, there have been studies that showed that transthoracic times can go up to the mid-20s in terms of seconds. But newer studies are coming out showing that when you compare it to transesophageal, we're talking a difference of 9 seconds. 9 seconds to acquire the images you need during rhythm check with TE as compared to 19 seconds with transthoracic. So clearly, this is a faster method of determining what's going on with your patient. You can also use it for compression quality. Now, we always think that we're pushing on the chest and we're doing great and everything is 5 centimeters deep, but I don't have a ruler on me during a code. But what you can do rather than just eyeballing things is you can use M mode through the heart. And what you'll see is you'll see the sternum, and you can follow that sternum up and down in M mode to determine, as in this case, that this person wasn't getting adequate depth of chest compressions. So you swapped out your rescuer and someone pushes harder on the next round of compressions and you can check your work. 5.1, that's good. But it doesn't stop just there. You see, in ACLS, we're taught to just push on the sternum and push down 5 centimeters and everything will be okay. But we all know that the heart sits differently in everyone else's chest. So what I want to talk about now is AMC. No, not for you day traders who are trading that stock. I'm talking about the area of maximal compression. And in this case, CPR is happening, but look, we're pushing over the left ventricular outflow tract, the LVOT, and it's getting pinched with every compression. This has been associated in animal studies and now in human studies with less return of spontaneous circulation, with a higher risk of death. So it actually matters where you push on the chest. And when you're using TEE in a live fashion, you can do goal-directed chest compressions. You can actually move people's hands on the chest until you get to a place where you are not pushing on the LVOT. And as you'd imagine, pinch on that LVOT, you're decreasing the ejection of blood flow that's coming out of that left ventricle. Procedural guidance, I don't think I have to convince many of you here. This is a case where they're putting VV ECMO, so they're putting in the IJ cannula. This isn't cardiac arrest per se, but it just shows you how you can visualize things. Look at that cannula coming into the superior vena cava. We can use it to drain pericardial effusions. We can use it to place transvenous wires. So procedural guidance is huge. Now, I'm sure more than one of you has said, well, I just can't do that. I'm not trained in cardiology or anesthesiology. Well, These 8 dudes came together a couple of years ago and put together a policy for ASAP that was a white paper and eventually became a clinical policy for emergency medicine physicians to do TEE in their hospital. The indications were peri-arrest and cardiac arrest. And so check out this paper here. Here's the PubMed ID. I'll leave it on here for a second. Check it out because it goes through a step-by-step way for you to learn how to use it, how to store it, how to clean it, how to set policies and protocols in your hospital. And certainly I'm always available if you ever want to talk about it. So 5 simple reasons for why you should be doing transesophageal echo. Now, I'm not going to be one of those people that says you should just do it tomorrow. You need to train, you need to talk to the stakeholders in your hospital to discuss policies and plans. But I guarantee you that this is something that will be in every emergency department in the next 10 to 15 years, because when we're talking about saving lives and we're talking about doing things better, I can't think of a better way to resuscitate people in a shorter amount of time than using transesophageal echo. Thank you for having me here today. I have my email on the bottom and my social media handle. I'm happy to take questions on chat or via email. Thanks, Sal.